Hey, y'all. Welcome to Questions You Didn't Ask. Did you know that this very spot could be showcasing your business or event? Whether it's an audio ad on our podcast or a visual ad on our new YouTube station, or even both, we've got the space for you. Naisha Frey Consulting is reaching a growing audience of over 1,000 leaders who are passionate about health equity, social justice, and civil rights activism. These are professionals just like you, working across higher education, research, healthcare, nonprofit, government, and even public health sectors. If you're ready to get your message in front of a dedicated and engaged audience, send me an email at Naisha Frey Consulting, LLC at gmail.com. Let's talk about how we can help you connect with the people who need to hear about your services and products that advance health equity and wellness. Don't miss out. Get in the mix and let's make an impact together. Welcome back to Questions You Didn't Ask. I'm Naisha Frey. Today, I'm joined by Dr. Shanita Randolph and Dr. Reagan Johnson from Duke University School of Nursing. Together, we're diving into how stylists and community spaces are changing the story of HIV prevention. This is Doing It for Ourselves. Let's get into it. One thing that I have appreciated, watching and listening to you, Reagan, is how you will point out the reality of what it's like to actually be a practitioner, right? Whether that has to do with time, whether that has to do with policy, whether that has to do with patient engagement, right? In terms of conversations and communication, like what's realistically going to happen when this thing gets implemented, right? And research, one of the things that I love about it is that it's so creative. You can be so creative, right? And sometimes we have research that is so creative and so innovative and so, unique that it doesn't fit.
Mm-hmm. Mm-hmm.
It doesn't fit in real life. It's a great idea.
Mm-hmm.
And if you were able to replicate those conditions in every community, then that would be awesome. But that might not actually be our lived reality.
Right.
And I see you pulling that into the conversation oftentimes.
Exactly. Because you have to think about, can it be realistically done? And then also, can it be realistically sustained? Right.
Mm-hmm.
Because anybody will take your $25 gift card or your $50 gift card and do it for the 6 weeks or the 6 months of a program or a project. Right. But can it become a part of your daily practice?
Mm-hmm.
That's the question. And so you have to design these things that it translates to the provider. Are they willing to do it? Is this something that, forget time, will they even do it, period?
Mm-hmm.
And then for the end user, the patient, does the patient want it?
That part.
And how do they want it? And how does that align with the research that these great innovations and interventions, is it something that the patient wants in this way?
Mm-hmm.
Yeah.
Mm-hmm. And I do think that that's an important point to make in regard to, what makes this dynamic duo so special and what makes this heat lab so effective. We've talked a lot about research. We've talked a lot about practice. And Shanita, you picked up on one of the limitations of research, which is that it oftentimes takes so long to translate, right? You said 17 years. I mean, there's some marriages that don't last that long, right? So, so you want to talk about commitment. So even with the power of research, the creativity of research, what are some of the other limitations of academic approaches to advancing health equity that you have seen in your work?
So many. The community, particularly, and I'm speaking from the lens of community engaged research, because that's what we do in the Heat Lab, right? We want to address these issues through equity, engagement, advocacy, and trust. If there is a problem, I'll give example on gun violence. the community, their thought is boots on the ground. Let's fix this problem. Like, let's address it. They're mobilizing grassroots efforts, making things happen, right? And being creative, being innovative in that space right now. It doesn't align with academia, right? And so we got to write papers about it. We got to prove that we're worthy of it. We got to go to conferences, national and international. Again, the pilot of the pilot. So I think that is a limitation in some of our structures and our systems, even from our regulatory, from our institutional review boards. You know, we have to make sure that things are done ethically, morally right. And although that is good, I think what we have done is created systems, though, that are making it more challenging. We made our good be evil spoken of. You know, even when it comes to engaging, you know, the community, and maybe if we're giving compensations, like we need their social security number, right? And you're asking immigrants or you're asking communities of color to give their social security number for participating in a research project. I'll pause. There's already a trust issue, right? I give my social security number to no one. So one thing that we do in the Heat Lab is there are opportunities to waive that for certain amounts. And so we have found some ways to bypass that. But it's things like that, I think, that are in our systems and in the structure on the academic side, that we have good intentions on regulatory, but our good intentions have also caused a lot of barriers and limitations. I think the other limitation is how we disseminate that information back to the community. And, you know, communities saying that, you know, I've been a part of this research, but I never heard what happened. Like, so how do you close that loop and make sure that the research that people are participating, that they know what's next? And we are very intentional about doing that in the Heat Lab, but that becomes a limitation because the next study, the person they don't see, what are you doing? Like, how is this really impacting my day-to-day? And I think that there are more strategies that we need to have to stop some of those limitations. Funding sources bring limits. You know, like, you can pay for this, but you can't do that. Yeah, it's even for community engagement. Like, if you get federally funded, you can't use any of that money on like a venue space. You can't use it on food. Anybody that you're part of the community, you need to feed them.
Yeah.
So
yeah,
the limitations go on and on and on and on and on. I've had quite a few, but we are working around them. But
yeah.
a lot can be done.
Right. And Reagan, you know, from your perspective, you know, looking at it as a doctor of nursing practice, how would you say these limitations affect practice and health outcomes, like with academic research?
Yeah, because like you said, it's a 17-year gap, right? At least a 17-year gap. Well, medicine changes like almost weekly. So in 17 years, whatever you came up with then don't matter no more, because we're doing something different now. It's outdated. It's a lot of it never even gets there. By the time it gets there, it's outdated, right? And so that has huge implications for health outcomes because patients are dealing with outdated ideas. You know, look at AI, for instance. We're seeing a huge shift to AI, and as Shanita said, the community is already using AI, looking up their own, diagnosing themselves with AI, and healthcare is behind the game on it. 50% of the people are resistant to using it. The other 50% don't know how to use it, even if they wanted to. So this stopgap between what we think, even what we think we need, or what could be created, and the time it takes to get there. So I think what we're doing helps that because we're shortening that time tremendously. So if we write a paper for an academic journal, we're also trying to write one for a practice journal so that practice folks can see it in real time, because their practice people aren't reading as much research journals. You know, they're going to read stuff about practice. If we put out something, we want to put it out for research, practice, and the community.
So this three-pronged approach, right? And so you're turning yourselves into little octopi, if I'm saying that correctly. But the point is that that's one of the reasons why you have a lab, right? You have multiple people working collectively with shared values and unique expertise to help drive that work forward in an effective fashion. And so when we think about that, we kind of talked around health equity. Like, I think my audience knows what health equity is because, I talk about it in every single episode. But if you could share with my audience a little bit more about, how does it show up in your day-to-day work? What is health equity to you, and how does it show up in your work, when you're doing research or teaching even?
So health equity for me is the basis from which I operate, right? So if I'm going to be delivering healthcare, then I need to do it in a way that is true to myself and my moral compass of who I say I am, my North Star, and that's health equity. And that's to treat everybody in the way that they need, right? Oftentimes we think equity means equality, that everybody gets the same treatment, and that's not equitable. And some people moved forward into health justice, right? Ensuring that everybody gets the very specific thing that they need in order to reach the place that they need to be. And I think that's where we should be moving. I think that requires a lot of, like Shanita said, policy and all that we maybe not be there yet. But what we can do individually is ensure that we're operating from this idea that we use this framework, 5 W's of health equity and research, of these principles that ask these questions of what does this mean for the community? Who's involved? Where are you doing this research? I can't think of the other W's right now, but there's this foundation that we operate from to say we can check ourselves, really, to say, okay, what are we missing? Who's not at the table? And how do we correct it in real time?
And just to help our audience and fill in the gaps before I move over to Shanita is, exactly what you're saying, just kind of checking ourselves, right? Checking in with ourselves from our values, right? And being consistent in terms of looking at the patient that you serve and thinking about, if I'm making a decision or I'm, having a practice, I got to think about who is impacted by these decisions, what values and resources are prioritized, what are activities, where are activities, and why are they being conducted? And so those I just did a quick search and was able to fill in that gap of what the 5 W's of health equity are. And I just encourage everybody to look that up and get some more information about who benefits, who is at the table, who experiences the negative impacts of inequities, and what values or resources or access opportunities are being prioritized or neglected. When are research activities held, and does this create barriers for certain groups? When do the issues being addressed by the research occur in a person's life? Where are activities taking place? And the list goes on. So I'm not going to read them all. I encourage everyone else to lean in. But I do want to turn to Shanita and ask a similar question of how does health equity show up in your day-to-day efforts? And I thank you, Reagan, for bringing up the 5 W's.
Yeah. Touching back on what Reagan said, right? Like, I have this leadership framework of leading from the inside out, right? You're going to lead based on your values. And when you think about, health equity, what is it, right? It's giving people what they need to live healthy and to reach their full potential. Health equity isn't what I do. Health equity is who I am. Like, as a leader, that's my belief, even in leading students or, being a leader for a research project, is giving people the full potential, giving what they need to have that full potential to be healthy. And I think that one thing that we can do in this space is, when we think about health equity, is taking an opportunity to reflect inwardly and to add those 5 W's, which, we contribute that to Keisha Bentley-Edwards and Nadine Barrett. They were 2 creators of the 5 W's, and they co-authored that manuscript that your audience may take a look at. But how do we do that? And what is our why? Right? Because if you can truly reflect on that in times like these that we are experiencing and have been experiencing since January of this year, you're not easily shaken. And I think that is a call to action for anyone that's doing health equity work, to ask ourselves this question that you're asking us, like, how does this show up in our day-to-day efforts? And it shows up internally in everything that I aim to do. And so therefore it's easy for it to show up when we're doing a research project to ask the community, what do you think about this and how do we need to shift this?
And then actually do what they say, right?
And actually do it. There are pieces of our project that have shifted, have changed in the middle of things because the community, our advisory council members, women have told us, no, that's not going to work out here in these streets.
Literally.
Scientific rigor was strong.
There you go.
Yeah, it didn't translate though.
If you're enjoying the show as much as we love creating it, consider showing your support by buying us a cup of coffee. Visit buymeacoffee.com/Naisha Frey O. That's buymeacoffee.com/Naisha Frey O. All one word. Each cup is just $5, and every single one helps us continue to produce, develop, and sustain the high quality content you've come to expect from Questions You Didn't Ask. Thank you for your continued support, and let's keep the conversation going. Right. So, I'm going to, we talked about, academia, the limitations and things like that. And we also talked about, translating to community. And one thing that we know is that, it takes money to do research and it takes money to create systems change, right? So we know the times that we're in right now, it's health equity, diversity, equity, inclusion have turned into target words, right? Words that have been targeted by our current 47th Executive Federal Administration to dissuade people from going down this path, right? And it's also, though, this conundrum of health equity is, at least for my audience, is seen as a moral thing. You guys have talked about how it's a moral issue, but it's also economic. And you mentioned Dr. Keisha Bentley-Edwards. She is talking about the connection between health equity and economic justice on one of my previous series. And so how do you communicate the value of equity to funders and institutions? Or does it shape who you go to for funding and institutions?
Yeah, I think it's both. And moving forward, I think that's one of the things that I've been thinking about personally and professionally with the Heat Lab is bringing on a business collaborator. I think a lot of what we do in this space has lots of limits because of the lenses in which we have been educated on how to address these issues, right? And so partnering and collaborating with business and entrepreneurs, I think is key. Understanding the communicating, I think, with funders, like, for example, where we are now, and even in this project, we've had people to ask us, why are you just focusing on Black women? Why only Black women? There's an economic piece to that, right? So if we can fix some of the barriers and the gaps for what is known and has been known for populations who have the worst outcomes, what we are doing is that is a standard and that we're fixing, but we're also, by fixing that, we're fixing it for everybody. Right? And so we're saving money. So if you can address the people and populations within a system that have the worst outcomes, you are fixing the worst things about that organization or about that system. And whenever you do that, you're saving that system money. You're creating better outcomes for everyone who comes across that system. So I know for me, I'm wanting to increase and show the dynamics of what that looks like from a financial perspective.
Yeah. Reagan, do you have any thoughts on that in terms of the economic translation of health equity research and how it plays into funding and things like that?
Yeah, I think for this, you've already mentioned this current administration and the cuts that have been made to government funding for health equity research, or the buzzwords of DEI and all of that. I think what's interesting is academia itself prioritized this government funding, right? You weren't really, you were a better researcher if you get these high level grants from the government, right? But now that everybody's scrambling to get funding, economic equity, and we're looking outside of those, and there's always been foundation grants and that kind of thing that typically align. I think now's an opportunity for us to look to organizations, large organizations and places who've not traditionally been stewards in that way, and how can they take some of their philanthropy dollars and open up grant funding. So the NBA, the NBA, how can they get into funding grants for really their base? These are predominantly Black leagues that we have to prioritize health, and maybe they have a specific way that they want to fund certain health projects. But can we be looking at all of these other businesses, like Shanita said, these large organizations that could be giving money and really funding this work?
And I'll just add, the Heat Lab, we have industry, private, public, and foundation funding, and also through philanthropy through our work with the PhD nurse scientist program. But the other piece too, just sort of to add to that, is this is an opportunity for us also to redefine in higher education what impact looks like. And how we create that impact, because we have created a structure that says to us as scientists in higher institutions that to be successful, you have to have federal funding from the NIH. That's what we've said. Right?
Or NSF, right?
Right. And I think what it does is it puts limitations on our creativity and on our innovation as scientists. Because at some point, what you are doing then, if you're not careful, is you start chasing the academic promotion and tenure agenda.
Yes.
You're not careful, and forget about why you actually went into this space in the first place. And so I think it's an opportunity to challenge higher education to rethink what impact looks like and how people are measured by success and promotion. Making sure that what that criteria is, that it truly aligns with what your mission is. And how you're measuring that.
I definitely get that. And I think that it's really important to say that, out loud, especially in the positions that you both hold as faculty at a top tier research, institution, that, the way in which academia is structured, that it can create a system that incentivizes people to chase the money as opposed to chase the mission.
Yes.
And so we have an opportunity to shift that. And we've talked a lot about the Heat Lab, but now I want to lean into it a little bit more. Shanita, I want you to tell us, what does HEAT stand for? And what are some of the standout projects that you all have innovated in through the Heat Lab?
Yes. And so HEAT is addressing health disparities through engagement, equity, advocacy, and trust. You might want to take this out, but AI has caused me to think that there are other ways we can actually make HEAT sound a little better. Like, so I'm thinking about how we can revise HEAT.
But I like it. I like it the way it is. So let's say it again for the audience with our full chest.
Addressing health disparities through engagement, equity, advocacy, and trust. And a lot of our work, again, has been partnering with the beauty industry, barbershops and beauty salons as trusted spaces in the community. One of the things that we have done in our beginning days was addressing sexual health among adolescent males and the engagement of their fathers. Partnered with 2 barbershops and 2 barber owners to co-create The Talk, which is an intervention that focuses on parent adolescent sexual health communications. We have created podcasts, talk conversation cards, which we are excited about those and moving forward with those. People are actually using them now. So these are conversation cards that give the opportunity for parents, adolescents, or for peers of adolescents to just have conversations around sexual health. And then our work also focuses on Black women and HIV. We have co-created with the community using PrEP, doing it for ourselves, Protective Styles, which is Updos, which is a 3-part intervention that focuses on bringing awareness and increasing the uptake of pre-exposure prophylaxis among Black women who currently are only like 1% to 2% of the population who actually use PrEP. So that's what we've been doing in that space. We've done a couple of projects focused around COVID and preferences, barriers, and facilitators to testing in the Black community. And, if we were to have another major pandemic, how best do we partner with the Black community to address those things as well?
So there's a number of different topics and partners that you all have covered through the Heat Lab. I'll turn to you, Reagan. How do you decide what problems to tackle? I mean, when I think about the Black community or health equity, there's so many things that could be, benefit from this type of collaborative research lab. But how do you all decide what problems to tackle?
Yeah, that's a really, really good question. I think for me, and I'll say Shanita as well, we both had very personal experiences with people living with HIV that we either knew or were close to in some type of a way. And that kind of guided or gave me a direction that I initially wanted to go in. And then you go out into practice or you go out into the community and you see that there's this gap that people don't necessarily understand that it's an issue or an issue for their community. And so I think that's been one of the kind of lampposts that we've used to choose a topic. I know that Shanita says this all the time, that HIV is where we are right now, but we have an opportunity to expand that. And once you find that your method works, right, then you can expand that to other topics that people need. I'll give you an example. Some of our earlier work, we asked women. I think that's another major way, like thinking about what position you want to make in the world and then asking the community that you're interested what they want. And some of that came back of, hey, yeah, we're interested in HIV prevention and sexual health promotion, but we'd also like that couched, within other health topics. So we want to know more about heart disease, or we want to know more about this. And so we've been able to kind of fortify the project with this other information. So we're not just solely giving what we want them to have, but what they're asking for too.
Yeah, I left out community and firearm violence. Definitely not one of our priority things, but what our theme is addressing health disparities through engagement, equity, advocacy, and trust, right? And so we did have a community partner who was a barber and a barbershop owner who helped to co-develop The Talk. And so he circled back around as the founder of Establishing Safe Cultures and reached out to the Heat Lab to partner with them in their efforts to address gun violence in the community. And so through Rita and Alex Hillman Foundation, we were funded to partner with Establishing Safe Cultures to address some of these issues. And so we've been working with Establishing Safe Cultures as a partner for the last year to address firearm violence. And what that has looked like is really positioning ESC and partnering with them in such a way that they can build their infrastructure, be in positions to be ready for funding to support the sustainability, and helping to inform their program in terms of some of the gaps in programming to prove that programming for the community throughout. And so, again, I think when you ask the question, how do we approach this? That was a great example. I think that it was definitely through community partnership and them reaching out to us for partnership.
That was Questions You Didn't Ask, hosted by Naisha Frey with Dr. Shanita Randolph and Dr. Reagan Johnson. If you enjoyed this conversation, tap follow and leave a rating wherever you listen. Spotify, Apple Podcasts, YouTube Podcasts, Audible, Amazon Music, or naishafrey.com/podcast. Share it with a friend who cares about health equity and community change.